Oh, well, it's not this joint too. As you're probably aware, is a joint meeting between North Devon Council and Torridge District Council. So, if you would bear with us, we have to individually go through a few formalities between the two of us for each council. Thank you. Firstly, I just have a few housekeeping notes to read out. If you would bear with me. Yes. To welcome councillors and officers from North Devon and Torridge District Councils, expert panel members and members of the public to the special meeting of the Policy Development Committee to discuss dentistry in North Devon. Reminder, please switch your mobile phones to silent. Can we ask please that those attending virtually to switch off your microphone to avoid any disruption during the meeting. The meeting is being recorded and will be available in due course on North Devon Council's YouTube channel. Please be aware that the purpose of this meeting is part of a fact-finding exercise to enable councillors and members of the public to be fully aware of the current situation regarding dental provision across North Devon as a whole. We will therefore politely request that anyone who addresses the committee or panellists to avoid making any political statements, to only ask direct questions, and that we keep to the schedule detailed on the front pages of the agenda. A reminder for councillors to ensure that those attending virtually can hear the proceedings and for the recording to capture the entire meeting, please ensure that you project your voice and speak clearly. To assist you, we have microphones which have been placed in strategic positions around the room. We also have an officer, Oriana, with a roaming microphone which will be passed to you when you are invited to address the panellists. Please remember it is a formal meeting and therefore do not refer to each other by first names. We are pleased to welcome the members of the public and press to this special meeting. As stated on the front pages of the agenda, at approximately 7:40, both chairs will suspend their standing orders to allow opportunity for the invited public to ask questions. The committee will then reconvene at 8:20 to consider actions and next steps. If you wish to ask a question at the point where the chairs suspend their standing orders, you will have the opportunity to ask questions and must indicate your wish to speak by raising your hand. We will then invite you to stand and you'll be given the opportunity to present your question to the panellists. As with councillors, we have a roaming microphone which for the purpose of both the recording and all attendees being able to hear the proceedings, we would politely request that you use. Given that there are likely to be a number of members of the public who wish to ask questions, and with the limited time available, please ensure that you just ask the question and refrain from making any additional comments. We will do our best to get through as many of the public questions as we can within the time available this evening. To ensure that this is possible, your cooperation will be very much appreciated. If, however, we do not manage to ask all the questions arising, we will make sure they are submitted to the panel after the meeting, and any responses will be sent to your email address, which we would ask if you provide to us at the close of the meeting. The timings for the meeting have been arranged to ensure that the committee members and the public have an equal and fair opportunity to address the panellists. Please remember that this is a formal committee meeting and it is important that respect is shown to the chairs, the invited panellists, officers and each other at all times. Thank you. We now move into the formalities of the North Devon Council meeting, special meeting of the Policy Development Committee. And item 1 on our agenda is apologies, please.
Thank you, Chair. I have apologies from councillors Ballard, Healy and Williams.
Item 2, item put forward, in which the opinion of the Chair should be considered by me as a matter of urgency. I believe there are none. Item 3, are there any declarations of interest, please?
I've received none, Chair.
Thank you. Item 4 is to agree the agenda between Part A and Part B. There is no Part B, so we continue with Part A, which is dentistry, to consider and discuss dental provision in the North Devon area. So I now hand over to Cheryl Cottle-Hunkin, Chair of the Torridge District Council Overview and Scrutiny Committee.
Is it working? That worked, yeah. So just for the formalities for our committee meeting, let's have an overview and scrutiny at Torridge. Number one, apologies for absence, please, Karen.
We've had apologies from Councillor Bark, Councillor Thomas and Councillor Johns.
Thank you. Urgent matters brought forward, the permission of the chair, I haven't received any. Number three, declaration of interest. Members with interest should refer to the agenda item and describe the nature of their interest when the item is considered. Number four, agreement of agenda items part 1 and 2. We don't have any part 2, so that's easy. And that's it from our side.
Thank you very much, Cheryl. I now have the pleasure to introduce our group lead for dentistry, Councillor Petrinos of North Devon Council. To John, please.
Thanks. Hi, everybody. I'm John Petrinos, and I've led the work on dentistry. We've done the little work we've done so far, which is basically putting this meeting together. First, I'd like to thank our panellists for agreeing to be here. We're very grateful. We hope that we might be able to identify some ways that our councils can help alleviate the present situation. In a moment, I'll ask them to introduce themselves briefly. We all know that getting a dentist, especially an NHS one, is extremely difficult. It seems particularly bad in our area, but that's just my impression. And that's why our two district councils are meeting jointly to see something we might be able to do to help. Although, as organisations, we aren't really involved at all in dentistry beyond responding to clear concerns expressed to us as councillors by people that live in our areas. I first belatedly realised what a problem there was with access to dentistry a couple of years ago. My dentist, which is in Barnstable, in Minehead, and said he might open a branch in the town I live in Linton if there was enough interest. I thought that was great, what an opportunity. So I contacted people who've been around Linton, but the nearest dentist in any direction is 20 miles away. And I was astonished to be absolutely inundated by nearly 1,000 people wanting to put their names down. And some of the stories I heard were heartbreaking. Many people had no dentist, of course. Some of the children as old as 8 said the children had never seen a dentist. There was a lady with impaired vision who had to get a taxi 20 miles to the dentist and 20 miles back again every time she needed her teeth treated. Other people had moved to Devon from other parts of the country and had to travel back to their previous dentist where they previously lived in Suffolk or Birmingham or Bracknell or Bristol or wherever, just for treatment. And in the end, there's still no dentist in Linton, nor was any prospect of being one. But Linton isn't a special case. Other communities can tell identical stories, I'm sure. Possibly worse, I hope not. So we're facing in Devon and the South West a national problem here. But I know it isn't the fault of dentists. They're most certainly not to blame. I hope tonight we better understand what the real causes of this terrible and growing problem are so we can figure out some way for our councils to help. It would be good to get our team into it. And finally, our panel tonight is quite small. We've had similar meetings in the past amongst other subjects like water quality or agriculture. We've generally had about twice as many panellists in order to get a range of views of different parts of the issues. We did invite a range of others, including NHS Devon, who commission NHS dental services, Health Watch, who are the voice of users of NHS services, but they were neither able to attend. We also invited a company called My Dentist that owns 550 dental practices across the UK, whereas most dental practices are fairly small organisations ministering to their local population. My dentist agreed to attend, but 2 days ago said that they wouldn't be here, which is a pity. However, they said they will answer any questions by email. So if you have any from My Dentist, please let us know and we'll pass them on. But we are lucky enough to have our expert panel of 3. So I'd like to ask them perhaps now to briefly introduce themselves, and then we can get on with questions as outlined by the chair.
I'm Paul Williams. I'm a specialist practitioner in orthodontics, but essentially I'm a dentist. I currently work in Bude. I used to work in Barnstaple, but when the contracts were up for tender, my dentist in the
Sorry, what's your mic working? It doesn't seem to be.
I switch it on.
is maybe I'm not close enough. Not used to it. So my name's Paul Evans. I'm a specialist orthodontist, but primarily I'm a dentist. So I obviously trained as a dentist first and then did specialist training. I currently work in Bude. I work part-time these days. I used to work in Barnstaple in a specialist practice, but when the tendering came up for the new contract, my dentist put in a better tender than the company I was working for at the time, Bupa, and we lost the contract and the practice that I worked in closed. And then my dentist tried to continue with the NHS orthodontic contract in Barnstaple. I liaise obviously with general dental practitioners on a daily basis to carry out and complete mainly adolescent patients care, but also adults as well. So that's me, all those.
Good evening, my name's Ian Rose. I'm a dentist based in Torrington, where I'm a partner in Torrington Dental Practice. Despite the accent, I've been here 30 years, based in Torrington for 27. I also work 2 days a week as an associate professor in primary care dentistry at the Peninsula Dental School, where my particular research interest at present is on recruitment and retention of dental workforce in rural and coastal settings. I'm also currently chair of the local dental.
Evening, my name's Chris Durham. I'm the dental practice. I'm a specialist actually dentist with special interest in orthodontics and primary care orthodontics. So not quite a specialist, but I orthodontics in the area. I did work at the practice at Paul earlier on. I was a general dentist here from 1997 to 2010, and then I worked in specialist orthodontic practice. I've got my diploma. I worked with Paul for many years, but then as he alluded to, we lost the contract at the practice in Barnstaple. We all got scattered to different areas as the orthodontic contract then was lost a couple of years ago. I am now, I think Zena believe wasn't she not taking on any more referrals. So I am now the primary person you refer to for orthodontics in North Devon. Very limited orthodontic contracts, and my waiting to go for the roof is not easy at the moment. I enjoy orthodontics, and I enjoy dentistry, but it's getting increasingly harder and harder over the last few years. So that's me. I work in 2 practices. I work in Northern dental practice, which is actually run by my dentist. I work at Queen Anne's Dental Practice, an independent practice with a small orthodontic contract there again, waiting list through. So hopefully solutions in the next few years.
Thank you very much. Thank you. We now move on to the section where I invite the members of the North Devon Council's Policy Development Committee if they would like to ask any follow-up questions. So,
Thanks.
between us, I'm sorry.
Yeah, thanks. I've seen £2 billion a year mentioned as needed to get NHS dentistry back to something like it where it should be. Does that sound right-ish? I know it's.
I think it very much is big in the area. My understanding is the current budget's under £3.5 billion spent on NHS dentistry. But if you look at the figures, that equates to delivering NHS dentistry for 50% of the population. So if you're looking at, it depends on the model of NHS dentistry you want to deliver. If you want, you know, the two main parties that both claim they want to deliver universal access for those that need it. If they're genuine about that, they would need to double the existing budget. And they also need to look critically at the contract which is being delivered under. But I think most of us within the dental profession and the wider public appreciate with the current economic situation, we're not going to see doubling of the NHS dental budget anytime soon. So we really need to be taking sort of responsible decisions about what we do with the current dental budget that we have. And I would suggest that we deliver it more equitably than it has been delivered at the present time. But perhaps that's something we can discuss later.
The other panelists wish to comment, please, on that.
I think with the current level of manpower and funding in NHS dentistry, realistically, I don't think it can provide the service that is portrayed and desired. And I think, personally, I think that you have to come back to essentially a kind of core service to provide people with what they desperately need. I think that's as much as it can provide in the current situation. And ultimately, I think you have to look to the private sector to provide many of the other services available. It simply is a model that doesn't work at the moment, and even throwing a very considerable amount of funding at it, you're not going to find the number of personnel you need to supply our population across the country with the dentistry that they very probably deserve, or certainly that they desire. So I don't think there's anything like a simple fix or just extra funding that would manage to address the problem. To look further back from that and look at the training of personnel, the delivery. The current contract needs to be very considerably revised.
I can just jump in. No matter how unpalatable that might sound, to most people, about having a core service which applies the face of NHS. I think if we're realistic, there's a core service being delivered at the present time, but it's not being delivered to those with the greatest need. It frequently is being delivered to the worried well, who are able to access the care, not to those where the greatest burden of disease lies. And I think that's the mature and responsible discussion that has to be had, perhaps not in a room such as this necessarily, but at a much higher level. And certainly there's a degree of frustration that post-COVID, some of these more radical decisions were made, and that the problems within NHS dentistry have just been continued to be compounded. And that's why you see this continuous diffusion of dentists from the NHS to the private sector. They've lost trust and belief that we're ever going to see any sort of change.
Thank you very much. Members. I think Councillor Knudsen and then Councillor Jones, please.
Thank you, Chair, and thank you for attending tonight. I don't know much about the subject, I have to admit, but I do know that 15, 20 years ago, we were not in this state. So can you tell me why it has come about and it's so bad now? What are the 2 or 3 main problems? It's all not to make it political, but I do know my old dentist, who was Spanish, left after 2016. And I asked him why he was leaving. He said, "You don't feel welcome in this country anymore." When I looked into it, I seen that there's been a lot of European dentists left. I don't know whether that's a significant or a minor issue, but there must be big issues that I'm not aware of fully of what they are. And I wonder if you just tell us what you think your thinking and main problems and how we got into this state. And then we get on to solutions possibly and what we can do. Why are we here? Right.
Okay. I'll kick off. There's lots of reasons. So about 15 years ago, something like that.
I know you're perfect.
Yeah, no, that's fine. And so when I first studied in practice in 1997, I think that year, I worked in the NHS, for many years. In 2006, and the NHS contract was brought in, which we did a pilot in 2005, yeah, which we thought actually this could work quite well. So the pilot for the new contract. When the actual new contract was then brought in 2006, it was nothing like pilot stuff. And they brought in the used dental activity, which is used dental activity. Essentially, it's how they governmental activity like treatments you provide. So certain treatments you provide, certain things you do. So free banding, so very simple band 1 for examinations, skin polishes, things like that. There's band 2 for restorations, refillings, that kind of thing. And then for anything involved in the laboratory, like dentures, crown, bridges, etc., there's band 3. And each one of those carry a unit of activity value. You have 1 UDA for band 1, 3 for band 2, and 12 for band 3. The problem being, say you had someone with high needs, in CU, then you do 20 fillings. That's a bit much for 10 fillings, 3 crowns, 3 fillings, etc. And you are contracted to do that, to provide the treatment for them, to bring them to health, and to improve them, to get their dental health where it should be. Say you had, you could then, you were, so say, let's simplification, you had 10 fillings to do one patient, you were that human with band 2, you were given 3 UDAs for that, whether you did 1 filling, whether you did 10 fillings. So, and you were paid a certain value per UDA you had. So 1 filling got you 3 UDAs, 10 fillings got you 3 UDAs. And all of a sudden, you can see that you're being paid the same whether you do 1 or 10. And it got to a point then the same thing with 1 crown, 2 crowns on the band 3. It just can't be done. There's no, I don't think there's anywhere else that you could go and you'd say, right, you can do this, but I'm only going to pay you 3 or 4 of these things, I'm only going to pay you 1 now. I lasted until 2010, I think it was, in general. After that, I couldn't find the quality of dentistry that I wanted to do. Now, happily, for my sake, my other interest, main interest was orthodontics. So I did postgraduate training, worked in Hall, and ended up just doing orthodontics alone. Because that's, even though the orthodontic contract isn't perfect, it's much better than the general contract. But I take my hat off to anyone who's worked since then. There are lots of dentists that after the 2006 contracts came in, that's when the big exodus started happening. So you saying back 14 years ago, that kind of, it would tie into that when the big exodus really started. If this contract was working on, it's just got worse since then. I don't know how it's still going now, but we at the beginning when this contract came in 2006, we said we had these problems with it. We said to the NHS and the powers that be, this isn't going to work. The BDA, the general profession itself, this isn't going to work. And here we are, nearly 20 years later, still with this contract. So if anything is going to change with NHS dentistry, the contract itself, the BDA has to go. The different contract has to come in. That's the only way it's going to work, but they still will cling to this UDA And it's happened. The Labour government brought it in, the Conservative government, as they were in Barnstable, it didn't do anything with that. So, it's a matter of really, it seems what political affiliation is there. Yeah, this whole system has to change before we install all that project. Really, sorry, I'm putting on that. It's there.
I'm not saying anything more about the contract, but if you start any day to start talking about the dental contract, that you can do get quite passionate about it because of the frustration. But the other key, I would suggest, first of all, that NHS access has been declining for many, many years. There has been a shift towards the private sector over the last 30, 40 years. But there have been key points that have escalated that shift. And one of them was 2006 contract. But the other issue around that contract change was the removal of registration. Prior to 2006, you are registered with the dentist, like you are a GP, you are no longer registered with it. Okay? So that's why you hear people say, I've been thrown out, I've been struck off my list. You haven't, okay? Because you don't have registration. It was removed in 2006. Okay? So previously you had a right to access care. You don't now. All right, so that's an important point. The other issue is,
Can I just ask why? I mean, why is it my dentist who must be up in a few months and this is time for a repair?
why do they ring you up?
Yeah.
And back to my earlier point, is we like to look after the worried well because we can hit our UDA target. So the other issue around this, I will not be political, but in 1999, Tony Blair stood up at party conference and said there'll be NHS dental access for all. By 2004, he was publicly saying that this is a problem that we can't solve, and NHS dentistry is the biggest problem. So I get slightly concerned when both the leading political parties claim that they are about to fix this. So that there were real challenges around that time. Funding, if you look at the National Audit Office report of 2031, which shows that there's been a 4% decline in funding in real terms for dentistry. Meanwhile, there's been a 9% increase for patient charges. So patients are paying more for generally a poor service. And the other thing is patient expectations. Expectations have gone through the roof. The bureaucracy, the regulatory compliance that we have to have as a dental profession now takes much longer to deliver, but we're having to run faster and faster and faster. Patient expectations, workforce patterns have changed in the last 20 years. It's very rare now of anyone working full time. There's lots of part-time workers, and there's various reasons for that. And then the international dental graduates, the figures don't. The figures from the General Dental Council don't reflect what your observation is. But it's not just your observation, it's lots of people's observations. But there is an incentive to leave your name on the General Dental Council register, even though you're not working. Okay, so, and the other issue is, sorry, I was quiet a minute, but the GDC registration is the number of dentists or dental care professionals registered in the UK made to work as a dental care professional. The numbers are historic. It's a historic maximum at the moment. I think it's 44,000 dentists. We've never had more, but we don't have the granular data to look at how many of them are full-time equivalent. Okay, and more importantly, how many of them are working within the NHS. So again, you need to be careful about what data we look at and how we interpret it. But international dental graduates, third of our UK dental workforce, dentist workforce, are from overseas. And that's something that we can maybe talk about solutions later on. We need to do more to support international dental graduates who come to this area and make sure they stay and get to school. Sorry, I've said too much again.
So I think you can look even further back than where we're going. And so back in even the 70s, some of the dental schools were closed. And there was a general prediction in dentistry that dental disease would be a thing of the past. And if anything, the demand, I think diets have changed and the demand for dental provision has vastly improved, whether it's aesthetic treatment or implants. So the various things we can do have certainly gone up. And my experience in children in particular is that dental decay has significantly increased over the last even few years. And I think to have an emphasis on prevention is one of the only routes that we could potentially take to try and reduce future loading and future suffering. And that was certainly a role for dentists. Well, it's still a role for dentists, obviously, but it was a role that many dentists jumped into. And I know at Ian's practice, they still go out to schools and they do lectures, and we used to do it as well from our practice. Chris used to go out and speak to schools and take them toothbrushes, but there's no incentive realistically, or not a significant incentive to do that. And maybe cut back the need. But I think an emphasis on prevention is definitely required to reduce the burden on them.
I think Paul makes a really, really important point there. And some of the data you may have heard around children's extractions. So children between the ages of 5 to 9, that's the most common hospital admission because of dental extractions. There's over 48,000 dental extractions every year under general anaesthetic. And the vast majority of these should be preventable. But the last year was a 17% increase. But oral health continues to improve in this country. But the burden of disease lies with the most disadvantaged. And I don't have data for North Devon, but if you look at Plymouth, the oral health needs assessment from 2021, 21% of 5-year-olds had visible decay. But if you look at the wards in terms of the most affluent and the most deprived, I might have to look at my figures here, but they were, I think it was, 56% decay in the most deprived wards, 7% in the most affluent. Okay, so it's about oral health inequality. And you'll find that those with the 56% decay will really struggle to get access to care. And they will be the ones that end up on that general anaesthetic waiting list, being subjected to extractions. It's an appalling experience for any child, no matter how skilled the clinicians are. And that, for many, will make them more anxious, more nervous about visiting the dentist if we can visit the dentist, and they're likely to put off seeking care until they're in pain again. So they enter this cycle of deterioration.
Thank you very much. Some James, please.
Thank you. Thank you so much for coming on. Already shocking and fascinating. So thank you so much. I had an example of 2 people recently where one was still being serviced by their dentist in terms of the NHS list, and the other, their dentist would no longer support them on the NHS list and they had to go and find another dentist. Now, both required, ironically, the same treatment. The tooth names and clean. I can't remember the exact figures, but this isn't miles away. The one doing it for the NHS, I believe it was less than £100. The one that needed to do it through a company that several of you have mentioned recently this evening, it was close to £1,000. Now, because of their circumstances, they had to actually make a choice. So they chose not to go ahead with that treatment. So much to discuss there, but are some companies profiteering from the current circumstances? Or is it just that is the true price and there's such a difference?
Okay, I'm not a politician, but as you'd expect, I'll wriggle a bit on that and say, unless you know the exact details, it's difficult to comment on the disparity in price. In answering your question, are some dentists profiteering? By and large, no. Yes, we all have outliers in every profession, in people that don't behave professionally. By and large, my experience is the dental profession they hold their heads up proud, and they do their best for the patients. It's dreadful when you hear stories like that. So, you know, my comment earlier about core service, you are going to get winners and losers. And there'll always be people in that middle ground who then take the hit, who are making perhaps not on exempt treatment, but the jump in price from NHS to private is significant. But you know, healthcare is incredibly expensive to deliver. High quality healthcare is even more expensive to deliver. You know, that's, we continually strive within every healthcare profession to improve quality improvement and try and offer safe, effective, and good experience for patients. And we're striven to do that, but we're also beaten with a stick if we don't, and that costs money. So, yeah, I mean that does seem a big thing, but it's difficult to comment. You know, if perhaps there was a root filling, a crown involved, you then end up with additional costs. And actually, on the NHS, there is you are subsidised still significantly. Although I see you pay 9% more, it's still a significant subsidy. You want to take property or question? I'm actually Paul.
I'm certainly aware of patients that have been to the My Dentist practice in Barnstable that have been offered private treatment, in particular in orthodontics, when they were still running an NHS contract and they were under the NHS contract by a different practitioner. I'm not sure about how reasonable that is to do that. But inevitably, I think there are dentists that will charge fairly extortionate rates. And personally, I couldn't sleep at night if I felt I was basically taking the mickey out of patients. It is very costly to provide services. There are different levels of services that you can provide for certain things. There's different options. However, I think it's inevitable, especially when the system is under so much pressure, that some dentists will charge a very high price for their time, as their time appears to be becoming more precious to the clientele that comes through the door. So I think there's a big disparity, but I think the vast majority of dentists work ethically and charge appropriately. Inevitably, there's some of those that don't. And I think patients feel that they've slipped into that situation, as much as it may be very difficult to get a second quote and a second person to see them. They can, because if they're in pain, it's just even more pressure on the patient. And there aren't enough dentists providing care, especially we're in a bit of a black spot across the whole country, and that will push the limits of what the treatment people will seek or pay for. And sadly, some patients will pay that very high price. Hopefully, they'll get fantastic care. I can only hope that that's the case.
Councillor Warden, next please, and then Councillor Wilson.
Thank you, Madam. Thank you, Madam. Still, it is. I've got a confession to make, first of all. I tended to get my dental care treatment in Pakistan because it's so difficult to get it here and it's much cheaper there. But having said that, it's quite obvious from what's being said tonight that the dental health of our nation and our area is actually deteriorating. And I just wondered what you would say would be the main cause of that. Would you say it's lack of dentists? Would you say it's cost? Would you say they aren't cleaned their teeth properly? Or is it because of more sugary foods that we're eating these days? What do you think is the major cause, or is it, do you think, a combination of all of them?
I don't think it is deteriorating. But that is just finger in the air, because unfortunately, we used to have an adult dental health survey and a regular child dental survey on 5-year-olds and 12-year-olds. But that's one of the things that funding has been removed from. So it's very difficult to go on the data. But I think where you are right is within certain groups within our communities, they are seeing huge deterioration in rural health, whereas many others are caries-free, decay-free, they've got healthy mouths, healthy gums, and they won't have problems throughout their life course. But there is still a group of patients who can't access care, who don't have the correct diet, perhaps don't have a toothbrush or toothpaste renewed regularly, perhaps don't brush their teeth regularly, and can't visit a dentist. So I think there are groups where the oral health is deteriorating markedly, and others it continues to improve. The cause of that, I think, it reflects the inequality that we see within our society, and dentistry is no different. And sorry if we're harping on, but one of the the NHS should be there to address inequalities. The current dental contract actually promotes inequality. It makes it more difficult to access care for everyone's in need. So that's one thing. Workforce, I mean, hopefully we can chat about that, but workforce is a major issue. Paul said, the number of dental schools closed certainly in my experience in the late 80s, I think were 3 closed because there was this naive assumption that oral health was improving, and they didn't take into consideration, the life course. Patients are living, we're all living longer and longer, even those of us from the West of Scotland. So we're living longer and longer, and we are retaining our teeth. We've got expectations that we're going to retain our teeth for a much longer time. So the demands have shifted perhaps from what they were years ago, what we have now, but there's still demands and needs, but we don't have a workforce able to deliver it. Now, there is a long-term workforce plan, which you might be familiar with, which was published last year. And one of the commitments is to increase training places. And that's something that Plymouth Peninsula Dental School is very keen to support. They put an application in for an extra 20 dentists to train. Challenge is, how do we keep them here? So I'll pass you on to Chris.
Yes, yeah, okay, yeah. Yes, so to what training, talk about recruitment really, and in this area, and go back to what you said about keeping people here with when there is do get there's graduates that do come down here, you have a foundation year, you spend in practice, and then to the retraining practice, and then a lot of absolutely, it's really one of the only ways that they can actually then get an associate to stay on. They can get a foundation to stay on. One thing ways to get an associate down here is the recruitment down in this area has been a real problem ever since as I graduated in '97, and when I announced the practice I was working on, I was thinking about staying on and bought a house for me. It was, I couldn't believe it. All right, great. And I'll stay ever since. I enjoy that. Some people don't understand why I don't want to work down here. I can't. But it is a big problem. Recruitment down here, when a dentist leaves the area, it's very rare that you'll get anyone from out of the area and down here. I don't really know what the solution is to that. It's always been a problem to have any solution. And we should think about getting rid of that. It's a critical one.
Well, I keep saying later on, when we start talking about solutions, but what can the council do?
Yeah.
You know, I know in many ways your hands are tied, but there are perhaps cross-working initiatives that we can look at working together around workforce, around education, you know, social care aspects of that. But in terms of my research in the Plymouth, we conducted a survey last year, and it indicated that 50, this was across Devon and Cornwall, 57% of the respondent practices were dentist vacancy. Some of them had up to 6 dentists vacant within it. And you could perhaps, for those of you in Bonsall, can guess which one that was. It was anonymised, so I can listen on. But the interesting thing was 48% of the practices had a dental nurse vacancy. The dentists can't work without anything. So, you know, there are real workforce issues. And part of it is, you know, as Chris alluded to, linked to dental foundation training. So you have to do a year. But it's incredible, some other research from doing at Plymouth, it's incredibly difficult to recruit and retain practices to offer dental foundation training. Because fewer and fewer trainers are working within the NHS, and there's an NHS commitment that you have to be a trainer. The subsidies or the support you get for being a trainer have reduced in real terms significantly, and you're being asked to do more and more because the younger graduates are coming out less clinical experience, they're also less confident, and they need more support. So you're getting more and more dental foundation trainers rolling out. And in areas where we've already lost 2 in North Devon in the last year, and we want to get trainees here to try and show them the delights of living and working in North Devon. But perhaps we're chasing the wrong people as well. And we can do more around marketing to the 30-something. That had their 10 years in the big smoke, and they've come back to, or they've stayed around the university, and they're bringing up a young family. And there was a quick fix. There's something perhaps we can think about promoting North Devon as, you know, as a great destination for them to live and work. We're not very good at doing that at the moment. But
On that note, we are sort of trying to keep to a bit of a strict timetable here, because clearly I'm due to hand over to the Torridge District Councillors, but I do have 2 more North Devon members who would like to ask a question. Can we keep the questions and the answers brief if possible, please? I have Councillor Wilson and then Councillor Bushell, and then we'll go to Torridge members. Thank you.
Probably start. You've actually gone on to answer part of my question, so that will make it a bit shorter, because my question was how can, thinking about what North Devon Council can do, how can we in North Devon make it more attractive for dentists to work here? How can we promote dentistry as a career to homegrown students, given that in one of the reports it says that if you are homegrown, you are more likely to stay in practice in the southwest. And I know that we're just publishing our joint economic strategy, and one of those things that we really want to see in North Devon is increased skills, coming out with more skills. We're sitting in our higher education place at the moment, and we really want to have a more skilled workforce, and we want to be a place where people want to stay and live and work here. And I know you've already started to answer that, so that's my question.
So I was looking, I think you might have seen my notes for solutions. I think I'll struggle to give a short answer to that, but perhaps at the end of the mock-up, we can talk about solutions, particularly around that. 3 of the key areas I thought we might be able to work around would be around lobbying, the obvious one, about just having a voice and being more vocal about the needs that we have as communities, but oral health promotion, what we can do in schools, in care homes and other things, about just shared working. And the other thing is around workforce. Okay, so maybe I can't really give much of a shorter answer.
Thank you very much. Yeah. Councillor Bushell, please.
I was going to ask why an establishment like the building we're in we couldn't do a partnership, because I understand they're already tied or were tied to Plymouth University, where you could do your first 2 years of your degree here and then go to university for the last one. But actually, you said that we're in a bit of a vicious circle, because even if we trained the dentists, they've got nowhere to do their foundation year. So how would we overcome that, and how could we, if we were able to try and lobby for the building we're in to expand the partnership they have or had with Plymouth University, how would we get the practices to do that foundation year?
Okay, so dentistry at the moment is a degree course. You can do it as a graduate, but there isn't an opportunity to do that as an apprenticeship. That's not to say that won't come in the future, but dental hygiene therapy, clinical dental technicians, dental nurses, there is an increase in development around apprenticeships. And Yeovil College is leading a lot of the work around that. And that's certainly something that, if you feel this is something you could explore, I can certainly put you in touch with people who are pushing that agenda very strongly. And again, it would suit really well. If you had a dental nurse, we had a dental nurse who came for work experience as a specialist, became a dental nurse, and actually she works at our joint practices, the other dentists at the back there. She went away to Liverpool to do therapy, and then has come back to work in North Devon. Now, if there was an opportunity for someone such as that to do 2 days in practice and 3 days in college or the other way around, that would be ideal. It's about that flexibility of training, and there are many ways that's being explored at the present.
They exist, the apprenticeships exist.
Yes.
For aspects of dentistry,
Not for dentistry, but as we're probably aware that some of the initiatives that are being introduced, I don't know whether you follow the debates around physicians associates at the present time, huge controversy about physicians associates replacing doctors. And I think if it's driven for the right reasons, we are all very, very supportive of it. If it's done to try and save money, I think you have to be very careful. Patient safety is absolutely paramount.
Thank you very much. Okay. I'm now going to pass you over to Councillor Copperman, Torridge District Council.
Thank you. Councillor Benton.
Thank you, Councillor. My question is aimed at Mr. Mills, and congratulations on your award recently that you received for your research, Mr. Mills. And it's really about recruitment, but it's really about the question: do you think that dentistry hasn't got the status that other clinical provision has in this country? And yet we all know that oral health is so important to physical health that it should have that type of incentive. But we're recently doing a new development, North Devon and Torridge development plan for the whole of this area. And all big housing developments have got to provide, well, we hope they will, social housing and also provision of some sporting activities and various other elements. For instance, we have a 750 housing estate being built above Billowford, and they're providing housing with shops and some kind of sporting stuff. Now, I'm not denigrating them in any way, but it does seem to me that there's no element of health involved in these provisions at all. It's like it doesn't exist. We actually have started to have a health and wellbeing working group as part of the development of the new plan. And I really do think that we should look at that health and wellbeing development group in order to include the importance of dental provision, particularly at a local stage in our area, which is completely lacking in terms of planning. And it's also to ask, do you think that the problem of premises is part of that provision at all? And also, I take the point about the units of dental activity. Having just come back from Harrodshire's grandchild sitting
where somebody who cleans a house, which is great and a very valuable person in the community, actually earns more than a dentist earns to do two of all three of these units of dental activity. So I think there's a fact that the status of dentistry is denigrated, it isn't appreciated, and it really is something that should be included in our local plan as an important strategic element for the local community. How do you think about that?
I was going to turn it around to you and say I'm probably not the right person to say that dentist status of the village. But you've answered the question, what's my dismay that our status has to be. But I don't know, it's certainly, still, if you look at applications to study dentistry, there are still, I think I'm right saying 8 or 9 applications to play. So there's huge demand to do it. The problem we have, there's a problem around recruitment about who we've got coming in, what we do to them while they're in there, and what they want to do when they come out the other end. Something happens in the application process or the interview process. They tell us how caring they are, how committed they are to the NHS, how they like working with people, how they want to save the planet, whatever it is. Something happens by the time they come out. They don't want to work in the NHS. So some of that's around the hidden curriculum. People like me that rant on, or my colleagues here rant on how dreadful the NHS dental contract is. So I'm then scratching my head if it's any wonder that no one wants to work within the NHS. And it comes from a good place that we want to improve in terms of conditions. We want to support our colleagues that are perhaps at the beginning of their career. But I think there is, despite all my bleating about dentistry, I am very privileged, and it's a fantastic profession to belong to. You can work flexibly, you can work anywhere in the UK, there's demand for your services, patients are appreciative of what you do for them, and you can earn a decent living. So, I think dentistry, and that's one of the things perhaps we can talk about later on, is about career pathways. And it's not just about dentists, it's about the whole dental team, but what we can do to inspire our local children or young adults, or even older adults, to look at a career in dentistry. And there are like so much within healthcare, within dentistry. There's lots of good little bits of work or best practice being done, but it's not joined up. So Peninsula Dental School, there's some fantastic stuff around widening participation. Our practice went to a Torrington school open evening. I worked at the dental school. They pitched up. I didn't even know they were going to be there. So we're not joined up. So we both ended up promoting dentistry. So there are things that we could do within the schools around that. And there are many like us who are passionate about the profession and would encourage people. Because no matter how much we bang on about how difficult it is, we do appreciate how difficult it is for many, many others, particularly those who are trying to.
There's a mic.
Thank you very much. First of all, I'd like to thank William Mills for all the care he's given me over the last 25 years. It's nice to be able to talk from that a mouthful of fire. We were talking earlier on about the quality of care, and in this area, as we're all aware, we're regarded nationally as being one of the more deprived areas. That must have some effect on this whole business about people not being able to afford to go to dentists other than through the NHS. So our area is one of the most deprived areas in the entire country. And I think that may also affect young dentists who are newly qualified and not earning the large salaries yet in terms of housing. I keep hearing about nurses not being able to afford housing, teachers not being able to afford housing. This must affect young dentists as well, and must go against the possibility of recruiting them into our area. Do those two things equate?
I think availability of housing is a challenge, and certainly we've got a new dental foundation trainee joining practice on the 1st of September. We had a meeting with him today. One of his challenges is to try and find accommodation for a year in town. So in terms of buying or purchasing a house, I think by the time most dentists get around to it, they're probably a better place to purchase a house than many others are. And when you think some of the alternatives, if you were slightly up country in Bristol, you know, the other challenges there, London, you know, a lot of young graduates go back to London or choose to stay in London, and they perhaps resign themselves to renting for a long period of time. And actually around the changing demographics within admission of dentistry, there's been a huge shift in ethnicity, and a lot go back to Birmingham, Manchester, London, and stay with parents, stay with the family home. It seems there's something in some cultures it's much more comfortable to do that. I appreciate Devon as a farming communities, there's there perhaps aligns with that. But for many of the rest of us, we move out of home, and the last thing we could imagine that my daughter would be coming back to live with me midwinter. So I think there are a number of things again we could look at, although there are many more people who perhaps need the support. It's maybe perhaps signposts of how you know information.
And as far as the inequality of care is concerned, the local population, does that equate to what you were saying about the percentages of people with less money in their pockets?
I mean, and this is just an observation that there are massive inequalities in North Devon. So you have many people who move here who have got significant savings and access to private healthcare, and you know certainly we see that within our own practice. But I take the point that certainly I think we sometimes overlook rural poverty and that we focus on the inner city. Mm-hmm. And people come down here on holiday and they see the beach and the sea and the moor and else, and they think, what an idyllic place to live. Everyone must be so fortunate. And they perhaps there's a sort of hidden rural poverty that isn't immediately apparent. And again, perhaps shared working, there are things that we can do to highlight the importance of having an NHS dental programme within our area for people like that to avail themselves. I don't know, especially
I think with regards to the inequality, and it's been said that the current contract for NHS dentistry is not quite the same for orthodontics in my provision of providing decent care orthodontically. But the general dentist contract doesn't really fit with being able to provide a good level of care and inevitably receive a reasonable payment for the time you put into that care. And running practices has become far more expensive, staff are more expensive, and the contract hasn't improved. And unlike other aspects of healthcare, so you may well see in the near future the doctors, general medical practitioners strike. You don't tend to find that in dentists. We don't strike. They are self-employed contractors on the whole. They will vote for their fee and they will move to a private contract. So I think the reform needs to be made at the NHS contractual level to attract dentists, certainly across the country, and to all the things providing somebody with a home, maybe the dentist tends to do fairly well because we have this ability. You can, well, I can't work for that, I can't make a living in that. Therefore, there are other avenues that you can explore, and there's not enough of it, so people can make their choices. So if there were more personnel, if the NHS contract was basically a better rewarding contract, then people would be able to provide care across the board. And I like working. I'm proud of working with NHS. And fortunately, my contract affords that for me. I don't think the general dentist contract does that very well, and therefore you don't tend to get people.
Then going back to what Paul said there as well, attract people to work in the NHS and new graduates, because I think that one of the ideas of being considered at the moment is tying in new graduates to the NHS, right? For a certain amount of years. I think that there's still not no shortage of applicants for dental places, but I think that a lot of the young students and a lot of the applicants are quite well aware of what the NHS is like, and I think that if you were certainly going to 5 years quite hard training, to be honest, and but hard training, and then you come out in the moment. Certainly a lot more debt than I was enough debt when I graduated these days. I don't know, a big amount of debt, and then you're then told you have to work in a system that is not just not a good system to work in for a certain amount of years. I don't think that's going to be a very attractive prospect for people. So I think that, personally, I think that would be putting people off it. But I mean, so if you, yeah, so like Paul said, this system needs reforming, which is, we're doing that, but the problem probably got that system needs reform to make it more attractive. The new graduates will be having to work in the NHS for a certain amount of years. Then you can actually provide the area to people with high needs. We started practicing Holsworthy many years ago, and I started still doing general practice in 2000 or so, and we were absolutely inundated. But at that time, we could provide a certain amount of care, a lot more than we could now, with this system. And demand was there then, and it has got worse since. The access has got worse since. But, these areas need this service, and we've got to make it, again, like Paul said, we've got to make it attractive thing for people to actually want to do, and be able to work and provide a good quality of service, really.
I would just echo Chris's sentiments about the tie. That was a recommendation within the NHS long-term workforce plan, and certainly something that we used to discuss, because I think it is quite a controversial issue. Some people feel, well, actually, the NHS is making a substantial contribution to these young graduates. Why should they come out and work in the private sector? I don't think that's the way to deliver a motivated, sustainable workforce, is to hold someone in a system that's not fit for purpose. So I have no problem with having a bursary scheme or a voluntary scheme or some offset against your student debt, but it has to be carrot, I think, rather than stick. And it has to, you have to come out and work in a system that delivers professional fulfillment, education, training, and other things. So I think that's a really important topic that will be discussed, I think, in the coming years. My understanding is new governments are interested in looking at this. But I think we have to be careful that we don't have a sort of emotional knee-jerk reaction to this and look at some of the unintended consequences. And it could be that at the first opportunity, these young graduates will get out of the NHS and will tarnish the NHS brand if people are tied into it with a difficult system.
Councillor Harden.
Yeah, thank you. I mean, it's been very interesting tonight, listening to everything. I've just had a letter from my dentist saying that dental practice and hopefully saying that they're losing their national health dentist, and so I don't need to go and make an appointment until they get a new one. Because I was on the waiting list, I keep on cancelling because I'm always going to different meetings. But basically, you covered the funding, the contract availability, recruitment, I mean, no doubt housing and Brexit and things like that have all got parts to play. Basically, dear Michael Mosley passed away, and he always had just one thing. So from this meeting, what do you think? Just one thing that we need to take back with us to help you.
One thing. One thing. What is the need for everyone? Well, might touch on lobbying, right? So we'll agree that that's something that we ought to do, whether it's press release from this, whether it's public meetings, whether it's something that we can do to just make sure that North Devon and Torridge has a voice. And I think we've done pretty well thus far, with press coverage at a national level, something for Devon and Cornwall. We just need to make sure that North Devon is and Torridge. So I refer to them both here. But if I pick, I'll go for workforce then. The other bit is workforce. I think there's things that we need to, if you look at short term and then long term. So short term, I think it's about perhaps within the two areas we map dental practices, the vacancies that are there, so we get a better understanding of actually within our areas what the nature of the problem is. So start off with some robust data. We then need to engage with these dental practices and say, how can we support you in terms of recruitment and retention? And that probably comes to marketing. Now, I don't know what expertise you have, or never mind resources, but I would hope that there's some way that we could pull together and work with the Devon Local Dental Committee to try and find a way of promoting North Devon and Torridge as a place to come and work. Okay, so that was one thing about short term. The other little bit is around the international dental graduates. We're not a particularly diverse community, and as I mentioned, there has been a big shift in demographics within dentistry. So we're on a wee bit of a back foot. But in terms of support networks, there's other things that we can do. Whether that's through the dental profession, whether it's the community clubs, in terms of signposting, and just making sure people are welcome, they've got the support, they know where to go to if there's a challenge or they want information and advice. So again, perhaps there's something around that. Long-term workforce strategy, I think we ought to be getting into schools, colleges, and promoting dentistry as a career. And that might be around dental nursing, clinic, might be around dental technicians. The guys and girls who make the crowns, the dentures, the bridges, and all these sorts of things. So some people have got fantastic skills, in terms of their arts, technical skills, but perhaps aren't so keen on working with people. People like me that quite like working with people, but I'm very good with the technical stuff. Which I probably shouldn't say that. So that would be I would say, let's have a chat with workforce, because I'm right in saying that as the county council, you have got a degree of influence over education.
In the district.
But you don't have much influence over health. Would that be right?
We're in district council, so we're not.
But you have a seat at county council, and you influence
councillors that sit in this area.
Yeah.
And we do work in partnership with the county council. So if there is lobbying to be done in the county, if there's lobbying to be done in the county council, then we can certainly.
Which I guess the question back to you as council would be, what can you do? Or what have you done already? What are you able to do? What can you do in the future? Because again, we are relatively naive, yes, maybe I am anyway, in terms of the roles and responsibilities and the control and the level of influence you have as council.
As I said, we certainly work in partnerships. So we work quite closely together as two district councils, Torridge and North Devon. And collectively, we work with other districts in Devon and the county council to try and further the interests of the whole of the county. And in particular, our interest is obviously our areas. So If there's things that we can do around attracting skills provision, for instance, to the area, quite like the idea of, how do we promote the two districts as an area to come and work with? We do that certainly for our own vacancies. But is there a question as to whether we could do that more broadly across the two districts to try and influence recruitment in other areas other than our own organisations? That obviously could be something like that, yeah. But in terms of trying to influence on the regional and national picture, we can certainly lobby. We have our MPs, and in North Devon area in particular, we're lucky to have our ex-leader, having just recently been elected as leader, MP, and so we're well aware of these particular issues. And we've got good links with both of our MPs, so we can start looking on that. But in terms of county council, there is something called devolution that's on the sort of horizon, and Labour will be picking this up as part of their new government, which is about giving more powers to local authorities and local areas. And I am sure there's a conversation to be had with government as to what those new powers might be. It could be more powers around education, more powers around funding, etc. So that's something that can feed into that process as well.
Yes, please. I just want to say that this ties in with what Mr. Mills says about the evidence and information available by liaising with various dental practices, which is something I did mention this morning. Because if that evidence is available, but we don't have it as councillors, then we can't really know the true serious nature of the lack of some health provisions, which would be included from dentistry. We do have this new working group, which is a joint working group with North Devon, to look at health and well-being as part of the local plan. This is new, and I do think that with the initiative here, this is a classic case where we can take this up and use it as much as we can, because we are restricted in a way in terms of the status of the district council, but we can use that health and well-being working group to ensure that we pick up the area of dentistry and make sure that that has some prominence in our local plan, so that we can then look at how we can take the opportunity to promote dentistry in schools, etc., but also perhaps to include it in the vital provision we feel would be necessary for a great big housing estate. Say it's over 250 houses, that there should be some kind of health provision included in that role, and there isn't at the moment.
The other element around schools is obviously about oral health promotion, and you'll have seen a commitment from Labour's manifesto perhaps about toothbrushing in schools, which if you look across other countries, Scotland, Wales, it's been highly effective there in reducing decay rates. There are challenges about how do you deliver that and who delivers that. But many dental practices have oral health educators, dental nurses, and I think if we can lean in on the Devon ICB, who you'll be aware, who are now responsible for commissioning dental services through the hub, perhaps there are things that we can do, again, not about career development, but more about improving oral health around toothbrushing and diet. Again, it's having a more coordinated approach within our areas than we have at the moment. It's an absolute lottery. We go out and visit schools, but it's hit and miss. And the same services perhaps in Ilfracombe and other places, but there's areas that just fall through the cracks.
Thanks for the times we've gone, but I have a few people raise issues with me and weren't able to come tonight, so I said I'd raise them here. And one was about the incidence of mouth and throat cancers. They increased as a result of being able to see their dentists, and who monitors that. I'll just read the rest out of voice. And emergency out of hours dentists. So you can ring 111 for other health issues, and but if you've got severe abscess. So one of my friends had a really bad abscess and some severe pain over a weekend and couldn't see a dentist. Tried to get antibiotics from 111. They said to ring the emergency dentist, but there was no answer. So they hung up and rang back and said that they had cystitis and they were able to get antibiotics over the phone for that. But the issue there is you've got people in severe pain who are unable to get the treatment that they need because they couldn't get it in hours dentists. But it's difficult with doctors. The next one, so this is I was part of the campaign to save mobile libraries, and that really highlighted the rural inequality, which we've already talked about, and Councillor Smith raised that. And the public transport being a big problem in rural areas. And I've looked, as part of that, I found out that there are mobile dentists that go around in rural areas, and I just looked up tonight, and Cambridgeshire, Northamptonshire, and apparently it's coming to East Devon in 2025 as a way to, as part of the, like a mobile NHS dental van. What's your view on that? Do you think it would be appropriate? Maybe we could put a library in there with the dental. And then linking into that, the lack of childcare provision and that impact on the dental workforce, because and the impact on gender inequality as well, I think, or equality, because quite often it relies on the mothers still, to the house of the children, and that living in a rural area, we haven't got that childcare available that we might have in other parts. And there was a report that came out that said that Torridge was one of the worst for childcare provision in the whole of the country. So yeah, if you could touch on any of those issues. And then we'll pass it
I'll get it first. One cancer. My understanding is there hasn't been an increase in incidence, but there's been a later presentation. So, with any disease, or particularly cancer, the earlier it's diagnosed, the better the outcome. And oral cancer in particular can be incredibly disfiguring if it's late presentation, and also the mortality rate is so much greater. And again, if you look at the groups that are most susceptible to that, there's a direct link to deprivation. Okay, because the key factors are smoking, alcohol, poor oral health in terms of oral cancer. So that is a real worry, and you'll see that in some of the published papers about if you can't access a routine NHS care, the person who's going to be looking at that for an oral examination is the dentist or the dental therapist. And it's really important. So if that falls off a cliff, you're going to get later presentation and you're going to get poorer outcome. Right. The other one was emergency outbars. I don't have one broken record. Responsibility was removed in 2006 with contract. Pre-2006, with registration, your local dentist was on call till about 10 o'clock at night, most dentists were, and over the weekends as well. They removed the responsibility and took it in-house to the primary care trust at the time. And then the staff back in 2006, 2007, it was staffed from a dental access centre in Barnstable, Exeter, and I think it was Torby, and might even be Tiverton. But they couldn't, there was issues around workforce, around funding, pull back. So now it's NHS 111, and you'll struggle to get out of hours care, which is appalling. So you then pitch up at A&E, or you get inappropriate care. Very few dental emergencies require antibiotics. It tends to be inflammatory rather than infective. So you need dental treatment. You don't need
antibiotics aren't appropriate.
Yes, particularly
dental pain.
Yeah, particularly ones for a UTI.
Yeah.
So, right, the next question I think was going to take public transport and mobile vans.
Public transport, I don't think, inevitably it would be great if it was better funded and easier access, but it's down to funding realistically, isn't it? And there's an awful lot of buses running around with one or two people, and people don't tend to like or a lot of people that tend to use the public transport services that are available in some.
Mobile dentist.
I don't personally think a mobile dentist is a terribly effective way of treating a significant number of people. The services that you require in a dental practice, they can be provided in a small unit, but I think dentists that travel around in a van and provide those services are basically spending a lot of time travelling and not a lot of time treating the patients. I think personally, I think the service would be better provided if you take the patients into the service. Those patients who can't attend, there are domiciliary services available. They're relatively sparse, but I think to provide domiciliary visits would be a better way around than having a van.
Can I just jump on the public transport? There's a shift within the NHS to centralised services. And some of that is post-shipment, worries about, single-handed dentists, as well as GPs. So there has been, but there's also the economies of scale. You shift to a larger hub. It's all very well in the centre of Birmingham or Bristol or Exeter, but when it's Ilfracombe and you're having to travel to, Northern to get orthodontic treatment, the very people you're penalising are, again, those who rely on public transport, not the ones who are a two-car family. So it's the inequalities yet again. So we need to be careful that by closing down small practices and having large hubs in some of the larger towns can disadvantage others. So in my opinion, you're much better off with a sort of hub and spoke model. And now that's not as cost effective, but it's certainly value for money for those that are having to access.
Same thing with regards to providing NHS care. The NHS contract needs to be fixed, and then that could be focused to deliver care in areas that are deprived of care and certainly deprived of, the social situation of people. That's a great demand on NHS services. So you could target those areas if you could attract the dentists in to provide those services. And that's only going to be done if the NHS contract is looked at and revised and repaired. And then if that were done, I think it would be vital for the commissioners to consider with an appropriate amount of diligence who they give these contracts to. Because corporate involvement in medicine and dentistry is corporates provide for the corporate. And I think you have to look at the ethics behind some of these services. And undoubtedly, small, single-handed and small practices that are personally owned, where the dentists, in my opinion, certainly seem to stay for a far longer time and the continuity of care is much better, should have maybe a helping hand. So maybe the helping hand that you could consider as counsellors to provide a centre and subsidise it to a degree, so that inevitably the dentists that work in that practice get better funding, and all the personnel that work in that practice can maybe support a slightly different type of care. The corporate model of pushing through treatments as quickly as possible or maximising profits for the corporate don't reward the dentists in a way in which it retains all of the staff in dental services. So the throughput of staff in corporate bodies is undoubtedly far greater and the continuity of care far poorer because of the system that we're now subscribing to. And the corporate model for dentistry, certainly in America and generally around the world, tends to go through stages where the corporates get bigger and bigger and bigger, and then there's a massive collapse and decline in that care. And it just starts up again. It's a rolling cycle. And that's one area where NHS dentistry, by commissioning a appropriate services with appropriate caring staff and rewarding them for that level of care that they can provide would probably present some stability and target the services to those people that need it most. But I think that, you know, I'm sorry to take us back to it. That wouldn't be something we could decide here, or even we could lobby maybe for a revision in dental contracts, and we could help out by providing centres where people can provide appropriate care. But there has to be a basic change.
But the responsibility to a greater extent lies with the commissioners. And we haven't talked a lot about the commissioners, NHS England, South West and Devon ICB. It's probably just as well we haven't.
No, thank you very much. Let's take the suspense.
Thanks, Sharon. Yeah. We've got a couple of formalities to go through again, I'm afraid, but it will be very brief. In order to open the meeting up for any members of the public to ask questions, committees have to agree to extend the standing orders. So I'm asking the members of the North Devon Policy Development Committee if we would agree to standing orders, please. All in favour? Thank you. Over to Sharon.
We've got slightly different procedures at the discretion of the chair. I'm not allowing members to speak.
So any members of the public who would like to speak, can you raise your hand, please? What's your question?
Yeah, this is interesting for a long time. Why aren't dentists? Why isn't dentistry truly part of the NHS? Like, you know, when I was a nurse working in the NHS, I got paid as a salary employee. My dad, when he's a GP, he was a salaried employee. And why aren't you guys salaried employees and being like GPs? You know, when I go to my GP, she doesn't say, well, there's a unit price for taking the blood pressure, and there's another one, you know, and I'm not having to go at you guys because I'm really, I am so pleased to be here and to put this question to you. I'm shocked that there isn't anybody who can help here. So why is that? Why aren't, you know, am I going back to 1947?
Yes.
Probably. You know, why, you know, and would that be an idea? Would that be a bit too radical that you were actually really true to a part of the NHS? And then that would solve all those training problems and all those, because it all sounds very piecemeal to me. The treatment does, and the contracts do as well. You know, and if we were all in it together, you know, and it would solve problems with, you know, pharmacists and things like that, you know. So, yeah.
I'm no historian. If you go back to 47, 48, you might be familiar with the quote that was stuff their mouths with gold, which was a reference to GPs, because GPs didn't want to work within the NHS.
They didn't, no.
And I think I'm right in saying it was Bevan that the quote was from. And dentistry, they very quickly realised within 2 years of inception of the NHS, is they couldn't afford. So for the first year, 18 months, NHS dentistry was free at the point of delivery. But within 2 years, they've introduced charges. Government. Okay, so NHS dentistry has almost never been free at the point of delivery. And they didn't buy out dental practices the way they bought out GP practices. So from almost the inception of the NHS, we're going down two different paths. And for them to try and retrieve that situation now, I think just wouldn't be feasible in terms of financial. You know, that for the government to say, okay, we're going to purchase, I don't know, is it 10,000, 12,000 practices, we're going to buy them en masse, and then bring in a a salaried model, your productivity and your performance is going to fall off a cliff. So you think most GPs who work incredibly hard and put in huge numbers of hours, they get a salary, but they have sessions for admin, they have sessions for phone patients, they have sessions for training, for audit, peer review. Dentistry doesn't have any of that. So if we're not sitting in a chair in a patient's mouth, we're not earning money. So it's quite a different model. And there are many people who believe actually if we had a core service, the way to deliver it is through a salaried service. But it will cost, and productivity and performance will fall off.
And there are salary dentists. They're very much fewer than they used to be.
Many fewer now. That was it. Tony Blair's model was around dental access centres, and which is what we had in Barnstable and at the end of the Street. So it is, but I think that was merged with community dental services, who we haven't talked about at all this evening. So community dental services are there to provide care for those with additional needs. Again, that's been massively underfunded, and you've got a contract that derives those with additional needs. And I mean, it's a very crude thing to say. We want to see people who have got healthy mouths and have very low needs, because we can hit our UDA targets. So anyone who's got additional needs makes it more difficult for our UDA target. So we get clawback and we get hit. So you push them on to the specialist services. And if you haven't got a specialist service, they're sitting waiting for months and months and months to be seen by community dentists. I haven't been very positive this evening. Paul will say something positive.
Hello. Hello. I think the panel are fairly familiar with me. Is it all right if I make a statement rather than ask a question, or would you like just questions? I'm Johnny. I'm a partner in Pure Dental, just around the corner.
I think that goes to the question.
Okay, so in terms of questions, in the commissioned UDAs in Barnstable, which is like a form of milk quota, so there was a ceiling on it. UDAs are mainly held by a corporate body, which has not arrived. Given that they have no dentist to fulfill the commitment, why do they keep getting commissioned the UDAs? And anytime there's a service, why do they apply for funding for the service ticket when they have no feasible way of delivering it? The statement was more tactful. And I'm aware that we have to email them to ask.
I think that question perhaps shouldn't be levelled at the panel. It should be levelled at the NHS commissioners, South West England, and now Devon ICB. But it is a cause of huge frustration. I mean, you're probably aware. I think there's a 5 million clawback for dentistry in Devon last year, and that money is not being used to commission more dental services. So that is from practices such as the one that Johnny's alluding to, and many others. My own practice was unable to fulfil its NHS commitment, again, because of largely of workforce.
Could I ask you to have a word that's after? Can I ask you to have a word that's after, so we can go?
Can I just before, my intention wasn't to level a difficult question towards the panel. My intention was to make a statement, but I wasn't allowed to make a statement. Thank you.
Hello. I was going to ask a question. The lady over there brought it up about the emergency care. I'm the parish councillor in Braunton, and so I know it's Braunton area, which is a much bigger area than Linton and Lynmouth, and we do not have enough dentists. I'm very fortunate at the moment to actually have an NHS dentist, which I'm amazed at, and twice about it. It seems not many people have. I did have an NHS dentist until February when she left, and then we just left up in the air with nothing, no options at all. Happened to call in about a month ago, and to my surprise, there was a new NHS dentist. But what I'm concerned about is the emergency care, and it's constantly coming up on local chat groups and forums and things where people are saying, I need some emergency care either for children or adults, both of them, and they don't know how to do it. They're told to ring 111, and then they're told to ring the emergency number. They ring the emergency numbers. I'm not just talking about half hours, I'm talking every day. They're told to ring up 8 o'clock. People are hanging on the phone for an hour or more, and then if eventually they get through, they're told there's no appointments left today. You have to try again tomorrow. And this is constant. And I have a personal experience of somebody in my family that's been in that position, and there just doesn't seem to be any emergency appointments anywhere in North Devon. It also affects people, like you say, financially impoverished people who can't afford to drive somewhere, or they can't get transport. They don't drive, and they can't get transport, say from Ilfracombe to Torrington. If there was an appointment in Torrington, they wouldn't be able to get there. And I just wonder, and most of them can't get through at all. And then people are advising, saying, well, there is an NHS dentist in Minehead, so, and they're saying, what's the number? And then, or they're going to Taunton or Exeter to find emergency treatment or get onto an NHS dentist. And I just wonder what your advice is for those people, because there's a lot, it's not just a couple, it's lots and lots of people who just are in that position. And I find that's really worrying. What are they supposed to do?
There is a bit of good news on the horizon. Provided you're talking about emergency care during normal working hours. If you're talking about out of hours, that's the responsibility of NHS England. As I mentioned, 2006 it was removed. So if you're talking about in working hours, the Southwest Local Area Team is responsible, it's been devolved to the NICB, but it's responsible for the provision of the commissioned services. They've identified there's a huge problem in terms of emergency care. Patients who have got an abscess, broken tooth, and a fall, and they have commissioned urgent dental care sessions from specific practices. Okay? Now, the next question is, if they have the tooth opened up or dressed, what then happens to them? And what tends to happen is they're out of pain, so they go away, they can't access a dentist, and the same thing happens again. So you're in a vicious circle. So they're now commissioning what are called stabilisation sessions. So that individual that is presented with pain and then be directed to a practice that's having stabilisation sessions, and they have a course of treatment to render them dentally fit. So that sounds like a good solution. So you sit back and you think, well, actually, we've created this problem in the first place. If you actually had the one dentist who was remunerated appropriately, and you had the workforce, you'd phone up and say, I've got pain. You'd be treated by the same dentist for your emergency, for your ongoing care, and then your long-term maintenance. So we're trying to sort out a problem that we shouldn't have been creating in the first place. But it is comes up 111. Not NHS 111.
To even get an appointment.
No.
That seems to be a very big problem. And also most of the people who are in this situation, like I said, they get the medical treatment, they then can't get an NHS dentist, or they've been dropped. I know for my one of my own daughters, because she couldn't get an appointment through the COVID period. Although they said they would take the checkups, they were not doing checkups in that time. And then they came to the point when they could come back and they said, oh, you haven't had an appointment for 2 years, so we can no longer have you on our NHS list. And that's, I've been in the dentist myself, I've heard them saying that to people. And, so it's a real vicious circle, because you then can't get an NHS dentist, you can't afford a private dentist, you then can't get emergency treatment. And then my mum was, she was going back to her doctor, and the doctor was reluctant to treat her because they said they shouldn't be treating her for an infection. In desperation, they gave her several different lots of antibiotics, but she just could not get an appointment.
But I think, we absolutely sympathise, and our reception teams are faced with this
Yeah,
every day.
it's not just my daughter. It's
No,
the whole range of people. It's constantly on
So I guess
chat saying, what can we do? You can't get hold.
no. So I guess my advice would be to, keep lobbying, keep shouting about this from the rooftops, so that we then start to see more rapid change and more effective change.
Too.
The NHS England, their MP, who are people who have got power and influence, because they are the ones that ultimately will make decisions about commissioning sessions. The horse is bolted a bit in terms of having this comprehensive care and going back to what we had in 2006. So they're trying to put a sticking plaster in place. But my worry is that you might have urgent care sessions in Ilfracombe and stabilisation sessions in Torridge. So we've got to fight hard to get as many of these sessions in place as possible. But bear in mind, with a finite workforce, okay, if they're doing stabilisation sessions and urgent care sessions, they're not seeing regular patients for routine care. So you're going to have winners and losers. I promise, it has been promised to me. I was at a meeting 2 weeks ago in Cornwall, and it's on its way.
Stabilisation sessions in North.
Yeah, we've got one a week at the moment, a stabilisation session in Torrington, and we've got another 2 coming on stream in September. But I don't know elsewhere in North. But don't tell anyone.
So are you saying there will be more availability for emergency?
Yes, but less availability for routine care, unless we get more dentists and dental therapists to North Devon.
I realise it's a vicious circle. Thank you. Thank you. Are there any other questions, please? I would just, before we talk about next steps, I would like to thank the panel so much. I know it's a smaller number, reduced panel, but I think the quality has been really, really high, and the answers they've been so helpful. I'm sure you all agree with me, but it's great. I just wish we could just do more, but we'll do what we can. Maybe, as you say, down to we'll be down to mainly us lobbying, talking to our employees. George, we can do some joint stuff here on this, can't we?
Yeah, it would be great if we could work together on bringing something together to lobby.
Yes,
Jointly.
Jointly, I think we're stronger together, as you're saying, isn't it? But did you say NHS England as well as MP? You said, didn't you?
Absolutely, and Devon ICB.
And Devon ICB, yeah.
I mean, I'm happy to lean in, I think they say nowadays, and support in any way.
Thank you. Can I hear what time? That's about all we met really, isn't it? Really great. Thank you very much. Councillor Bushell, did you?
Yeah, something just came to me while the members of the public were asking questions. I think in your initial addresses, 2 of you said that you were working part-time. If we had you working full-time, you'd have more appointments. So should we lobby for something like a tax break for dentists to encourage them to work more, or are there other reasons? Is it a very stressful job, therefore you need more off time to be able to cope with the time that you are working?
So I work part-time in practice and part-time at the dental school, and my life would have been affected by
so if you can work at the dental school, we can have more appointments.
Yes, but we're significantly older than the week, Paul and I. It's the Devon air makes us look so much fun.
So it's a choice.
I say I work part-time, but I still work 40 hours a week. When I first qualified, I worked in the hospital service. Some weeks worked 120 hours, and those times have gone. So junior doctors work far fewer hours. And the thing that was great for me was I had a fantastic experience of everything that we think because I worked so many hours. But the times have changed, and people, especially down here, I think if you can promote living in the southwest on a outdoor lifestyle and get more people, there needs to be more training places, a bigger skill mix to cover different aspects of dentistry. And then you might get more personnel to do it. And ultimately, yes, it is a stressful job, and becoming more so. The governance of dentistry has increased really very dramatically, and it's one of the things that the corporate model, one of the things they can take off you is some of the clerical and governance issues, and they have an economy of scale, but they also have a hierarchy of personnel to pay. So I think the first thing is try and increase the number of training places. Maybe don't expect people to work that many more hours, because people would be driven. I don't think you could cut out tax breaks for dentists in particular. I think there would be a bit of a backlash if you did that. And there's tax or pension breaks for judges in particular, and they have relented on the pensions, because there was a big concern that a lot of us would go on carrying on well. You might as well just take the pension and get off out of it, and I think that's helped a little. But yeah, I pay a very significant amount in tax. I'm kind of happy to do that. I've always never shied away from paying tax, because I've worked, the vast majority of my work is within the NHS, and that is funded by the tax. So I really don't shirk my responsibility on paying tax. Dentists can make a good living, no doubt. So I think you have to remunerate people and give them, a nice lifestyle in a nice part of the world. Yeah, I'm really shocked that more people don't come down to work. But it's not just down here. It's across the whole country, and even to a degree, across the world. There's not enough trained personnel.
There are shifting attitudes within younger generations, and sometimes as an older individual, you can look down your nose and you don't like the 60 hours a week, whatever, what's wrong with you. But actually, I'm not sure who's the one that's right and who's the one that's wrong.
You spend most of your time looking up people's noses.
They look above.
Put out the height reference.
I'll just bring in one more question, if that's okay with you. Just a cheeky one from Councillor Jones.
Yeah, it's an observation, because we just brought up again, it's been coming up throughout the evening. We're all blessed by the fact we live in such a wonderful location, and there's always more we can be doing to promote it. The district council we have the same challenge, and it's a big problem. And the team have just been very proactively creating content and videos, and approaching local government graduates at fairs and events, and taking content, taking videos, and it's worked. And we've filled some positions by doing that. And I'm just thinking, perhaps we could take what we've already created for that kind of thing. Could we be holding a workshop for local industries? Could we be connecting you to the right people? And could we be giving you marketing kits and giving you the stuff and saying, go and approach, let's talk about how brilliant North Devon is, and the surfing, the beaches, all the lovely countrysides. That's something we physically could do. We've probably actually already got stuff we could give.
I think that's a great. We had a workforce, Southwest workforce task and finish group. We knew what tasks were, and it finished before we actually delivered much, so it's no longer in place. But I banged on about marketing, and I think as a quick fix, that's what we should be doing, because trying to develop new workforce is going to take years, and we ought to be doing it. But as a quick fix, we have lots of dental exhibitions, trade exhibitions, and conferences, and a Peninsula Dental School goes to some of them. Some of the colleges go to, some of the Royal Colleges go to them. But why, as Devon or North Devon and Torridge, why we're not out there? You go to one at Excel, and you have people from Australia and New Zealand marketing come-to stories in New Zealand. Depending what resources you have, I'm sure we can support that in terms of manpower. I'm chair of Devon LDC. We are reasonably cash rich. We've got loads of enthusiasm, loads of ideas. And if there was some way that we could help support that, because it's in Devon dentists' interests to bring more dentists to the area. And again, that's the value of this, I guess, is that we probably don't appreciate the connections or the opportunities until we start getting around.
That we can discuss. Well, I don't know, to Councillor Cohen.
I just want to thank you again for coming and speaking to us and informing us. It's been brilliant to have you. Thank you for working together on it with us. I think we've got a strong voice together. That's it.
And finally, everybody's going to say, it's one of those meetings, isn't it? No. What we'll do next is, I mean, we've obviously going to have copious notes of this, the whole thing's been recorded. And I've been making notes to be going through things that sort of came out that we might have some sort of interest in, or influence or impact if we try it. But we'll certainly be working further on this than before, and I'll be in contact. I've got your email, Ian, so I can contact you. And I know Kelly's got everybody's. So I say thank you very much. And we will have to take this forward because there's no point trying to attract people to Devon if they end up in pain and get back to Birmingham.
Thank you, John. Before I formally close the meeting, I'd like to thank all our officers of North Devon, the work behind the scenes, especially, and thanks to Oriana for running around with the microphone, but especially to Kelly. I can ask her to minute and thanks to herself. She's put so much time and effort in, and I think some of them haven't realised, how it's difficult to get everyone together. Really. Well, thank you, Kelly, for that. I've read the questions. It's been really interesting. I don't know that you've read so much tonight. It's been put over in a way that I can sort of understand it, but I don't understand the system still. But it's been very interesting. Thank you so much for coming and giving us your time.
Thank you.